Welcome to the Cleveland Clinic Masters in Medicine Educational Series. I'm Dr. Marc Pohl, and I hold the Ray W. Gifford Chair in Hypertension, and I'm head of the section of clinical hypertension in the Department of Nephrology and Hypertension of the Glickman Urologic and Kidney Institute. I've been working in the field of hypertension and nephrology for many years, and I'm delighted to share with you today some thoughts about the management of resistant hypertension. Now, there's a lot of discussion about initial therapy for mild hypertension or mild essential hypertension. Should we start with diuretics first, or beta blockers, or ACE inhibitors, and the initial dosages and lifestyle modification and so forth. We're not talking today about mild essential hypertension. We're not talking about dilemmas or controversies in the management of mild hypertension. What I'm going to discuss with you today are those patients who appear to be incredibly difficult to control. People who are taking 2, 3, 4, sometimes 5 drugs, sometimes 6 drugs, come to your office and the blood pressure is not at the targets that you were hoping for. So we're talking about a different kind of patient. I sometimes use the term stubborn hypertension or stiff hypertension, the kind that really appears to be extremely difficult to control. And it's a very common problem in family practice and general internal medicine, and is the sort of problem that generates many consultations for hypertension specialists. Now, when we use this term refractory or resistant hypertension, you might imagine that this is a little bit troublesome, because if I were to ask you to define resistant hypertension or refractory hypertension, or if we had an audience of 300 or 400 people to define resistant or refractory hypertension, we'd have many different definitions. Why is this a troublesome term? Because there's so many antihypertensive drugs available, and there's great variability in physician prescribing practices. Everybody might have a different definition. So how might we properly define this term in the setting of many drugs available and many different ways that we physicians and nurse practitioners or physician's assistants, all of whom manage hypertensive patients, how can we really define this term when there's a lot of variety and variability in the way we do things? And these are just some of the problems in trying to establish a good definition for resistant hypertension. For example, at what level should the blood pressure be? And then you're not able to achieve it before you call it resistant. Which blood pressure parameter? The systolic blood pressure, the diastolic blood pressure, the mean blood pressure, maybe the pulse pressure? How many drugs does a patient have to fail on before you call the patient resistant? Which drug combinations must the patient be on and then be unable to be controlled before you say that patient has resistant hypertension? And as if these problems are not enough, what should the appropriate drug dosage be before you say that the patient is failing to be controlled on the regimen that you have prescribed? Well, the subject of resistant hypertension really became a popular subject many years ago with a classic article in the Annals of Internal Medicine by 2 of my mentors, both unfortunately deceased, the late Ray Gifford and the late Robert Tarazi, when they put together this article for the Annals of Internal Medicine on resistant hypertension in 1978. And at that time, they said resistant hypertension might best be defined as the failure to control blood pressure adequately, and they defined adequately as less than 150 over 100, with a good regimen, provided that the medications are taken as prescribed. And in that terminology, good regimen, they went on to say that that should include a diuretic. Now, over the years, when I've talked to physician groups about this subject, resistant hypertension, and depending on where the lecture might be and in what setting, I've used anywhere from 3 to 5 other definitions of resistant hypertension set forth by major gurus or thought leaders in the field of hypertension, just to make the point that every major instructor and teacher and expert in hypertension has had some variability in his or her own definition. So, for example, I would often like to use John Lara's definition of resistant hypertension, or Norman Kaplan's definition of resistant hypertension, or the late Harriet Dustin's definition of resistant hypertension, all of which might be slightly different than the original Gifford-Tarazi definition, just to make the point that there's some variability in these definitions, but there have been common themes to all of them that focus on a so-called good regimen or a sensible regimen that should include a diuretic. And of course, the most recent definition of hypertension that most people hang their hats on is the JNC-VII definition of resistant hypertension, which was defined as the failure to reach goal blood pressure in patients who are adhering to full doses, that's an important concept, of an appropriate 3-drug regimen that includes a diuretic. JNC-VII's definition of resistant hypertension went on to emphasize that part of this definition should include certain targets. And they said systolic and diastolic targets that are less than 140/90 would be an appropriate level that the physician should try to reach. And if you couldn't reach 140/90 on a good regimen, as in the paragraph above, that would be called resistant hypertension. And the reason they said that is because treating systolic and diastolic targets to less than 140/90 is associated with a decrease in cardiovascular disease complications. They went on to include in this definition, in patients with hypertension and diabetes or renal disease, the goal blood pressure should be less than 130/80. So let's say you had a patient with type 2 diabetes with 2 grams of proteinuria and a serum creatinine of 2 milligrams per deciliter. They would say that resistant hypertension would be the failure to reach a goal of 130/80 on full doses of a good 3-drug regimen, including a diuretic. And if it was a patient that did not have diabetic nephropathy, they would say failure to achieve the goal of less than 140/90 on a good regimen should be called resistant hypertension. Now, there are 2 basic patterns of resistant hypertension. The first is so-called primary drug resistance. What we mean here is that the hypertension persists despite adequate therapy in the absence of a definable pressure mechanism. And this occurs really in a very small percentage of all these hypertensive patients that we see, in only about 2 to 3% of the hypertensive population. And the second pattern would be a patient who'd been controlled his or her life for many years, suddenly becomes resistant to a drug program that had previously been very effective. So, for example, you see somebody in your office that's 72 years old, that has had hypertension for 20 or 30 years, always controlled on a low dose of a diuretic, now comes in and the blood pressure is 180/100 and seems to be requiring 2, 3, 4, maybe even 5 drugs to control the blood pressure. This would be so-called acquired drug resistance, and that usually reflects a secondary cause of hypertension, which we'll review at the end of the hour. And at this age group and with this history, that patient that suddenly develops severe hypertension who was previously well controlled, now 72 years of age, almost always would turn out to have renal artery stenosis or renovascular hypertension superimposed on previously long-standing essential hypertension. Now, there have been very few very good studies on the prevalence of drug-resistant hypertension. And if you look at the first one and the third one, the Anderson study and the Alderman study from the mid-70s, you can see that we're back pretty close to that 3% figure that I mentioned to you on the previous slide. In other words, the prevalence of true drug-resistant hypertension, when we can't find an obvious reason, is very low, about 3%. Several years later, the Swales study from the UK had a much higher percent of resistant hypertension in their series of 957 patients. The reasons for this difference are not clear, but we're not looking at 20 or 30% of patients with resistant hypertension. And it may be, as some of you may recall, that in the United Kingdom for many, many years they were sort of anti-diuretic, whereas Alderman from the worksite studies in New York, the United States was very pro-diuretic, and the UK was sort of pro-beta blocker and anti-diuretic. And maybe, I haven't looked at this Swales paper in a long time, but maybe one of the reasons for the higher prevalence of what they called drug-resistant hypertension was because of not as many patients receiving diuretics in their series. As I say, I'd have to go back and look at that hard data again to be absolutely sure of that interpretation. Now, another attempt to look at the percentage of patients that had so-called refractory or resistant hypertension came from Yakelovich and Henry Black when Henry was at Yale many years ago. This was published 20 years ago in the Archives of Internal Medicine. And they looked at 436 patients that were treated at a hypertension referral clinic. 92 or 21% of these patients had refractory hypertension, and of these 92 patients, in 83 patients, a cause was identified, the most frequent being suboptimal therapy. In a moment, I'm going to call that physician resistance or physician noncompliance, and we'll address that in the second segment of this discussion. In these 83 patients, blood pressure was brought under control or improved in 58 of them, and you can see the causes: suboptimal therapy in 43%, drug intolerance in 14%, a previously unrecognized secondary form of hypertension, we'll review those in the latter part of the hour, in 11%, patient noncompliance in only 10%. In my experience, that percentage is much, much higher. Alcohol abuse, office hypertension, drug interactions are much smaller percentages in this series of an attempt in a specialty clinic to characterize the reasons for so-called refractory or resistant hypertension. But it's for many years been my habit and my practice in advising physicians on how to approach the patient who appears to have resistant hypertension, to go through this list, which I learned from Ray Gifford many, many years ago, and this approach is the substance of his classic 1978 article in the Annals of Internal Medicine. The first is patient resistance, or so-called patient noncompliance. What are some of the features about the patient which is making them appear in your office all the time with blood pressure that's uncontrolled? The next big category is physician resistance, or physician noncompliance. The things that you and I do wrong, or areas where you and I could improve what we do to help get patients' blood pressure controlled, such as you and I prescribing medications in too insufficient a dose, too infrequent administration, irrational combinations. For example, I've seen patients that come in on a beta blocker, an ACE inhibitor, and an ARB in full doses, good doses of 3 drugs, and the referring physician says, I can't figure out why this patient's blood pressure can't be controlled. That's because those 3 drugs are all working on one part of the physiology that controls the blood pressure. There'd be absolutely no reason to think that using those 3 drugs together would control the blood pressure in somebody with stiff or difficult hypertension. Sometimes we are inadequately educated about the importance of keeping after patients who have difficulty with blood pressure control. And for some of us, depending on our specialty, there are other areas of medicine which, turn us on a little bit more than just getting the blood pressure under control. So sometimes the physician may not be as motivated to make the blood pressure target as he or she might be for certain other conditions that are more appealing in terms of personal interest. Certain drug interactions, eating too much salt, so-called office hypertension, some have called it white coat hypertension, a previously unrecognized secondary cause of hypertension, such as primary aldosteronism, which is being recognized more and more these days, a pheochromocytoma, renovascular hypertension, hyper or hypothyroidism, progressive renal disease, birth control pill hypertension. These are secondary causes of hypertension that might be the reason for difficulty of controlling the blood pressure. And so that after you review reasons for patient noncompliance, physician noncompliance, drug interactions, too much salt, office hypertension, secondary causes of hypertension, when you've excluded all those possibilities, then you're left with that 2 or 3% that have true drug-resistant hypertension. Well, let's talk a little bit about patient resistance, or so-called patient noncompliance. First and foremost is inadequate adherence to the therapeutic regimen that you and I have prescribed. And inadequate adherence to the therapeutic regimen falls into two broad categories: dietary or pharmacologic. Dietary problems would be the patient who's eating too much salt, the inability to reduce weight, or excessive alcohol consumption, particularly binge drinking. So I try, when it's possible, to avoid seeing my hypertensive patients who admittedly drink on Monday mornings, because if they've been drinking on Friday, Saturday, and Sunday, and you see them on Mondays, you're getting the lingering effect of the binge drinking. So see your heavy drinkers in the middle of the week if that's possible, if your scheduling or appointment system will allow for that. There'd be a HIPAA violation to ask the patient over the phone, if they were drinking over the weekend. But after you get to know the patient and you can control it a little bit, and you can't stop the binge drinking, which would be the best thing to do, of course, for their general health, then try to get them back on a day other than right after the weekend binging. We now know that obesity is a big contributor to difficulty controlling blood pressure, and we know that weight reduction will result in anywhere from 10 to 20 millimeters of mercury, a reduction in the systolic blood pressure, which, as you know, at least in people over 55, is the most important blood pressure parameter. And eating too much salt is a big contributor to refractory hypertension. Now, pharmacologic reasons for what we call inadequate adherence to the therapeutic regimen would be the patient who just simply fails to take the prescribed drugs. Maybe the patient is not taking prescribed drugs because of the complaints of sexual dysfunction, which is a big reason for patients not taking many of the drugs that we prescribed, and failure to follow the prescribed dosing schedule. Discontinuing medications because the patient feels well or thinks they're doing well, or 30-day prescriptions. 30-day prescriptions, particularly in parts of the country where the weather's bad at certain times of the year, like up north. So the pharmacy only will allow a patient to have 30 days, or the doctor writes for 30 days, and then there's a snowstorm when the medications run out. The patient never gets to get the prescriptions refilled, then may forget about it. So I strongly urge my colleagues and folks like you who are listening to this discussion to write for at least 60 to 90 days. That avoids the running out of your medicine problem. Inadequate follow-up, and then we have things like substance abuse, particularly cocaine. We've already talked about binge drinking with alcohol, amphetamines, and so forth and so on. Now, this is a very important slide. It's a great take-home message, and it talks about how you and I might estimate a patient's sodium intake. Now, remember that the amount of salt, or for all practical purposes, anything that you eat that can be measured in the urine, what comes in goes out. Or to say it another way, what came out in the urine is what went in the diet. So that, you know, the normal sodium diet would be about, you know, 150 to 200 milliequivalents of sodium a day. If someone eats a lot of high salt foods, cheese, products with tomato sauce, all the barbecue sauce, ketchup, mustard, and of course eats the foods that are obviously salted, pretzels, potato chips, and so forth, then they're eating probably 200 to 300 milliequivalents a day. Bachelors that eat out all the time are always eating a lot more salt. Salt, tremendous amounts of salt in soups at restaurants, chili in restaurants. Or if a patient says they salt their food heavily and they salt their food before tasting it. That little bit of history gives you the clue that they're eating more than 200 to 300 milliequivalents of sodium per day. And how do you know that? You know that because you measure the amount of sodium in a 24-hour urine collection. Every time I order a 24-hour urine collection on a patient, I'm a nephrologist, so I'm always looking at 24-hour urine protein determinations or creatinine determinations, and I always order a sodium with it because that tells me more than probably a lot of the tests that you and I order all the time. So if a patient has a 24-hour urine sodium excretion of 285 milliequivalents, that means that's the amount of sodium that they have been eating. And you think they're eating 90 milliequivalents a day because you told that patient to be on a low sodium diet or eat 2 to 3 grams of salt per day, or even 3 to 4 grams of salt per day, or 2 grams sodium diet, 1 gram sodium diet. Each gram is about 43 milliequivalents. So if someone's had a 2 to 3 grams sodium diet, then they're in that top range of 90 to 120 milliequivalents per day, and that's pretty good. And if you get a 24-hour urine sodium excretion on a patient and it comes back 85, then they're doing very well with the salt in their diet. Patients today are very salt conscious as part of our health, food, exercise, wellness craze that we've been in for about 20 years. That's a very good thing. And as many times as 20 years ago when I used to see all these patients on high salt diets now, that is a less frequent reason for so-called refractory hypertension. But you only know it when you measure the 24-hour urine sodium excretion. Unless you give the patient a list of foods to favor and foods to avoid, and I do that. I have a little cheat sheet in my office. Column A is foods to favor if you have high blood pressure. Column B is foods to avoid if you have high blood pressure. Sometimes I'll give the patient that list. Look at this column of foods to avoid. I'll be back in 10 minutes. I'm going to go see the next patient. I come back and then they're smiling and they say, you know, doctor, I eat this, I eat all these things. I eat them all. Well, that's why they probably have refractory hypertension. So this is a very simple trick, and all of you can use this in office practice to help you sort out the reasons for refractory hypertension. Other clues to poor patient compliance: evasiveness to direct questions regarding adherence, vagueness about the names of the pills, what they look like, their color, how often they're taken. Are they capsules? Are they round? Are they square? If patients don't know the names of their pills, if they don't know what color they are, if they don't know they're scored, if they don't know whether they're capsules or tablets, they're probably not taking them. Missed appointments. Patients miss appointments if the weather's okay, if there's not a good reason, and it's appointment for blood pressure follow-up, they're probably not taking their blood pressure pills. Complaints regarding side effects, particularly sexual dysfunction that I alluded to a moment ago, and complaints regarding the cost of medications, a big issue today. If any of these things are going on, you should ask your patients, or if you have a system in your practice where the nurse gets all this history first, or an MA, or a physician's assistant, if any of these issues come up and the blood pressure is not controlled, that should raise a red flag that the patient may not be taking their medications as you think they are. Other clues to patient resistance or patient noncompliance would be a resting pulse rate of 90 or 100 in a patient who you think is taking a beta blocker. And then maybe they're not taking their beta blocker because it makes them tired or because of sexual dysfunction, and the heart rate's 95. Now you've got that. They're not taking their beta blocker. You have somebody on a thiazide diuretic, or you have somebody on some chlorthalidone, which is coming back into style as it should be. We'll discuss that later on after the break. But on someone on hydrochlorothiazide, a uric acid level that does not increase, or a serum potassium level that does not decrease, in a patient supposedly on a thiazide diuretic, suggests that maybe they're not taking it. So you see a patient who's taken supposed to be taking hydrochlorothiazide, 12.5 milligrams twice a day, and they've got a uric acid level of 4. And maybe they got a serum potassium level of 4.8. Unless they're on several other drugs that would make that potassium be 4.8, that combination, a low uric acid level and a potassium level right smack in the middle of the 4 milliequivalent per liter range, might make you think that they're not taking the thiazide diuretic. Very simple clues that we've just reviewed for so-called patient noncompliance. Now we get to physician noncompliance: inadequate patient education, inadequate drug regimen, inappropriate dosing, inappropriate use of omission or omission of diuretics. And I think this might be a good place to take a break, and we're going to come back to physician resistance or physician noncompliance after we have a short break. Thanks very much for your attention.